Hello, everyone. I'm Leah Klinke. I am the Assistant Vice President of Hospital Revenue Cycle at WVU Medicine, and welcome to this breakout session. This is the first thing like this I've done, so I apologize if it's a little awkward. So we've been using the MAP app for a relatively short time, but I wanted to go through kind of how we're using it and kind of why we're using it. And how we use it to communicate organizational performance to our leadership team. So first, I'm just going to kind of go over our organization, WVU Medicine, and how we're structured. And then I'm going to talk about why we use the MAP app versus maybe using other benchmarking tools that are available to us, and then ultimately how we're using it. So first, I'm going to go through I only have 4 slides, so I'm just going to go briefly through the slides. If you have questions during the presentation, you can type them in the chat, and then when we get to the questions section, we'll go through the questions that have been asked remotely, and then if we have time at the end, we can do raising hands and asking questions and have a conversation. I think this breakout session was intended to be a conversation, so that you could ask me questions and possibly I could ask you questions about how you're using it. And we only have 30 minutes, so hopefully we can get through a lot of this and have some interesting conversation. So WVU Medicine is West Virginia's largest health system. We currently have 12 hospitals, and I am over hospital revenue cycle, not physician revenue cycle, so I'm really focused on the hospital side. We have 12 hospitals. 11 of those hospitals are currently on Epic. We are adding hospitals all the time. And this picture actually is the most recent picture that I could find of the state and our system, but it changes so quickly I can never get one that has everyone on it. We're acquiring hospitals at a relatively quick clip. So the most recent was Wetzel County Hospital that was added in July, and it is not called out on this map as part of the system. It's called out as a managed hospital, but that's the path to joining our system. So as I said, 11 of our integrated hospitals are currently on Epic. We convert newly integrated hospitals to Epic typically within 6 months of them becoming part of the system. So Wetzel County Hospital, who joined the system in July, will be going on to Epic in November. So it goes really, really quickly, and we grow and grow and grow, and just kind of bring them into the family as quickly as we can. That means that we do 1 to 3 Epic conversions a year, hospital conversions. The way that we're structured as a system is I am responsible for the hospital revenue cycle. As soon as a hospital is on Epic, their teams get integrated into our team, and ultimately I become responsible for their revenue cycle on the hospital side. The hospital CFOs within the system are still responsible for their own financial performance, which makes me kind of be almost like an outsource to the individual facility leadership. The system, our costs ultimately get allocated to the facilities, and so I am accountable to them, although I don't report to them. The other thing that we did recently in January of 2019 is because the changes were happening so quickly, it was hard to keep the existing business office structure of each business office independent. And so we did a whole transformation where we created a centralized business office in January of 2019. And it's done entirely virtual. So we kept all of the existing staff that are located at in different towns around the state who've worked for these hospitals typically for years, and we incorporated them as part of our teams, and they do report within our structure virtually, which actually, when COVID hit, it kind of was a positive thing, because we already weren't working physically together, even if we were working in a business office. So when a lot of our staff ended up going home, it didn't really cause a lot of hiccups to our management of our teams, because we were already doing most of that management remotely. So why did we choose to use the MAP app? So we're on Epic, and for those of you who are on Epic, you know that you have access to benchmarking tools within Epic. And we did use the Financial Pulse tool to kind of see how we were doing against other facilities. But there were a few things that came up that made that not necessarily the best tool. One of the things, like I had explained before, is that the CFOs are our clients, and so we feel like we need to be able to report the data to them in a way that makes them feel comfortable at the service that we're providing them. So we got lots of questions about, like, how are you setting your targets? And when we initially did our restructure, we really were comparing ourselves to where our baselines were. So what were the results that they were getting as an independent business office, and are we able to get the same or better results as a system business office? But that really wasn't satisfactory. They want to know, how are we performing? Are we the median? Are we the top quartile? They want to know how they're doing now. Obviously, they have little control. They want to get the best results that they can get for their facilities. And then the other question was, I want to compare, I want my facility to be compared to other facilities like me. And because we have one very large academic medical center, it tends to be the center of everything that we talk about. And the facility CFOs who had the small critical access hospitals were not interested in being compared to the academic medical center. They wanted to be compared to other hospitals like them. And the financial pulse allows us to do some of that, but not quite as granular as we're able to do in the MAP app. The other thing within Epic is that your operations decisions impact the result and how you're benchmarked. And so, like, we post 84% of contractuals at the time of billing for both inpatient and outpatient. So for AR days, we actually look pretty good in financial pulse, but that's only because most of the numerator of the calculation is at net, where we're comparing ourselves to facilities that may not have as much of that number be at net. So it's not really good. I don't think it's okay for kind of seeing where you are, but it's not a great, like, benchmarking tool to see where you are within the group. Are you top quartile? Are you median? And so we felt that MAP app gave us, because of the standard calculations that they use, it gave us a better external benchmark to be able to say, like, where we are compared to others. And so how we use it is that we met as a group with the leadership, and we chose a few benchmarks that we felt like were the important ones that we wanted to be measured on. Of course, there's a lot of metrics, but we chose a few that we felt were important, especially at the beginning of our restructure time. We worked with HFMA to come up with custom viewpoints. And so each CFO has their own custom viewpoints. So we have, like, a critical access comparison view for our critical access CFOs. We have their facility view. We have a system view. And so they have all those viewpoint tabs established, and they're customized for each CFO. We also developed reports for each CFO to show how they're comparing to their peers, and we set those to be sent out automatically every month on a particular day. They get those via email as a PDF, and then me and my team will meet with each CFO monthly, and we use the MAP app report as our kind of primary discussion report. Kind of how were things this month? Were we looking better? Were we looking worse? And then ultimately, it gives them an opportunity to ask us questions about any concerns that they might have, any additional questions where we can kind of dig deeper on any of the numbers, etc. So that's how we're using it. It's worked pretty well. The CFOs all have a different appetite for, like, are they actually willing to go out into the tool and look at how each facility is doing? And that's why we make sure that the reports get pushed out to them so that they can have them in their inbox, and then we discuss them to make sure that they're reviewing them and that we're actively communicating how we're doing, and if there are any issues that we're having that are making the results slip. So those are the only slides that I had put together. So what questions does the group have for me?
Hi, Leah. I'm not sure if I'm supposed to unmute or I'm just going to go for it. Can you hear me all right?
Yes, I can hear you.
Great, thanks. My name's Jake Hess. I'm from Spectrum Health in Grand Rapids, Michigan. My question is, was it a hard transition when you went from just using Epic reporting to transitioning over to the MAP app tool? We are recently implemented system with the tool, and right now we're using Epic as our source of truth. And our large concern is if we use some reporting from Epic and some from the map app tool, that we will run into a lot of questions of, well, which one's right and which one's not. Do you guys solely use this, or do you use a mixture?
We do use a mixture, because of course the Epic dashboard also gets emailed out to the CFOs. So like my boss might be looking at one thing from the Epic dashboard, and then, other people may be looking at the map app and stuff. And I just try to make it really clear about the different meaning of each of the metrics. Generally what you see in the Epic dashboard should follow similar trends to what the map app metrics are showing. So if you see an upward trend in aging, you're going to see an upward trend in aging in the map app as well. So the map app really, because you don't see it every day, it's like once a month, we use that as a discussion of how we're doing compared to our peers. But of course, we're in the Epic dashboard every day. And
Okay.
Some of the CFOs, like I said, some of them are in Epic, like interacting with the dashboard. Some of them are getting the Epic dashboard emailed to them, and some of them really aren't looking at it much at all, and are just like looking at the financial packet that comes through. And I think it hasn't really been a big problem. And it's interesting to talk to the different CFOs, because some of them are like, they don't like the Epic numbers because it's so clearly not what they're used to seeing.
Yep.
Because the numerator, it looks really low, and they're like, I don't really understand what that number is, but like when I show them the map app, they understand that number.
Yep.
And so, it's nice to have both. I find the Epic dashboard a wonderful tool for my management team and for me, but I've not found it to be a great tool for trying to communicate to a CFO, how we're performing.
Yep. Very fair. Thank you.
What other questions? Is anybody typing questions in the chat?
I don't see anything. If you would rather type it in the chat, feel free. If not, you can unmute yourself and ask away.
Okay, somebody did chat to me. Do you do drill downs on things like DDFB days by financial class? So the map app, and it was explained to me this way because I had some questions about like drilling down within the map app into kind of getting down to what's actually happening at the granular level. And it's really more of a high level benchmarking tool, but it's not going to give you the drill down into like financial class level information on DDFB. I would use the Epic dashboard for that, but we also use, because we're submitting our data to the map app manually, so we have data sources that we're using, and I have an analyst who pulls it together every month and submits it. And so we use those tools of the data that we pull together from the system, and then we will use that information to kind of further drill down into problem areas and try to to identify opportunities, like detail opportunities of action items that we can actually do to try to move the numbers. But DDFB is one of those things, I don't know if this came from our spray. I don't know if you're on Epic, but in Epic, the discharge not final bill is called candidate for bill, and there's just a ton of detail on the dashboard of drilling down into what your opportunities areas are for discharge not final bill. So we would use the Epic dashboard to get down to the nitty gritty there. I mean, as everybody knows who's on this call, it's an everyday thing, kind of digging into your numbers and trying to make yourself better all the time. And we use all of the different tools. And again, map app really is that tool that we use to communicate to leadership, financial leadership especially. And then we have other tools that we use when we really have to get granular down to the account level. Okay, someone said, I'm assuming peer groups are different for within your system. So do you have difficulty having enough participating peer hospitals? So, so we talked a lot when we were setting up the reports with the CFOs on what they wanted their comparison groups to be. And so for most of the facilities, so we have 5 critical access hospitals. So the critical access hospitals really wanted to be compared to other critical access hospitals. So their comparison group for the critical access hospitals is other critical access hospitals. On the acute side, almost all the CFOs were comfortable using the HFMA benchmark group, which has to do with a kind of a net revenue comparison, like what is your average I think it's monthly net revenue, and then size. I think bed size is a part of the HMA comparison group. One of our CFOs wanted us to get more detailed than that. So for our large academic, we got more specific to only compare ourselves to very large hospitals. So occasionally the critical access group does not produce a benchmark for things like initial denial rate, which I would guess some of that is a technical barrier maybe on the systems that those facilities are using. And there sometimes there's a lag too, because we submit our data early. And so if I produce my report today, I might not have a benchmark comparison group. When I look at it next month, I may have one. So critical access for some metrics, we can have trouble having comparison groups. And then also for our large academic, you know, sometimes we don't, like, there aren't enough facilities reporting at the time that I run the report for discussion with the CFO to see the comparison group for the month. It hasn't really been an issue because I think for pretty much for everything there's at least some sort of comparison, either for the prior month or like for, we talked about like broadening the comparison group if we felt like it became a barrier, but it's not been a problem enough for us to change the comparison groups. That was a good question. There have to be more facilities getting on the MAP app so that we don't have gaps in the comparison groups. What other questions do folks have?
Leah, this is Andrea. Can you hear me okay? I'm curious how, with you know, all the different CFOs that you work with, all the different types of providers, how are you responsible for prioritizing the opportunities for each CFO, or do they do it?
No, I mean, most of it would be me, because we're kind of communicating to them the initiatives that we're working on in order to improve the metrics. And the ones that, when we did our restructure, we had some significant slip in results. And so we're now getting back to the point where things are looking a little bit better. It was kind of like a perfect storm. We implemented the MAP app, our results were really bad and still getting worse. So it was a really painful monthly discussion with the CFOs. But we've now really kind of come out of that initial lag of the restructure that we went through, and are seeing our results get better. You know, a lot of the projects that we're working on are working on all the metrics where we don't necessarily good. The ones that were big target areas for us were aged AR, generally AR days, of course, which aged AR influences. And so we've had some projects that we've been working on, like automatic claim statusing is a big one that we were working on that have really contributed to a decrease in our aging. And so generally what we'll do is, especially for the metrics that don't look particularly good, is that we'll talk through with them kind of what the initiatives are that we're working on to try to improve the metrics. Because of the way we're structured, we tend to see similar results across the system. It's unusual to have like one facility have something that looks particularly bad and another facility have that same thing look really good, because we have the same people working the same accounts for those facilities. So I mean, it creates discussion. Like lately, like I included point of service collections on the report because I feel like it needs to be a priority for us, and because we need CFO buy-in in order to implement upfront collections. We really do very little of it now. So I included that on the report, and this month actually was the first month where I think half of the CFOs were like, "What are we doing to make that better?" Which was great because they're all really engaged now in improving point of service collections. We planned on this year being our year to really kind of ramp up point of service collections, but with COVID and people losing their jobs and things like that, we didn't think it was a great time to kind of start the initiatives, but we're starting to work on it now. And just having that metric on the report that we talk to them about every month, and it looking the worst of all the things that we're talking about, it kind of prompted them to ask the question of like, hey, should we be doing more with this? Which is great because in the past, some of the CFOs, because of the concern for their communities and things and the reaction of the community, haven't been super supportive of that initiative. So I guess it's a combination.
Thanks, Leah.
I'll just say another thing about communicating the results the way that we do. The other thing is that, I personally, I don't want anybody to ever be surprised by anything that we're doing. And like when our aging was growing and things like that, like I'm glad that I had a tool that I could have a conversation with them every month about, because they need to react to changes in AR, changes in aging in the reserves, and make sure that everything is kind of looking okay. From a financial perspective, they have to make decisions based on what's going on with AR. So I feel like the tool gives us the opportunity to communicate our results, even if it's a painful conversation about us not necessarily doing the best that we feel like we should, in order for them to react and to feel that they have control over what's going on, kind of like they did when they owned their own revenue cycle.
Leah, I would love to get your ideas on how we can make that easier to communicate to the CFOs. I know that's not always easy to do. I like to believe that if everybody understands the map keys, they'll understand what they're seeing. But would love your input on maybe things that we can do in the new tool to make that a lot easier. We'll still have all the report sharing of viewpoints that you have today. But if there's something incremental that can help with that, I'm all ears.
Yeah, I mean, I don't really know. Like, I feel like a lot of CFOs, they understand the base metrics, but I do end up explaining it again, like, because and that gets back to the question I got earlier. There's so many different ways to calculate some of these metrics, and there's things that they see every day that they're calculated differently than in the MAP app. So like in Epic, when you look at aged AR, it's showing you like a percentage of the total AR, including undischarged AR. But when you look at the MAP app, the denominator is only billed AR. So it makes your percent look higher because the denominator is smaller. And so I do end up explaining those differences, but I really don't know if there's anything the tool can do. I just think it has to do with kind of the fact that there's a lot of different things that they're seeing, and they're all producing something slightly different. And so I don't mind explaining it again when somebody has a question about why it looks different than, like, why did the days in the MAP app report look different than the days in the Epic dashboard, et cetera.
Well, and just so you know, as we work on kind of consolidating our map keys from hospital and physician into one consolidated set, we are adding 2 new keys, which look at your aged AR, factoring in your unbilled as well. So we'll have the 2 aged ARs for billed, and the 2 aged AR keys, including your unbilled.
Yeah, and I think one of the things that's always a struggle when you're comparing your when you're comparing yourself to someone else is that there are always differences in how you operate, and sometimes there's not much you can do to make yourself look good. Like, for example, our academic medical center, we can have newborns in-house for 2 years, and most of them are Medicaid, and we don't have the opportunity to bill those accounts until the patient discharges. So we end up with a lot of like undischarged AR, and there's nothing I can do to get that money faster because the state doesn't pay interim claims. So, I mean, there's just different things like that that I think sometimes make it difficult, but we just have to like kind of take those out and say like, okay, this is something that we really can't control. If you're going to include in-house or unbilled in the number, it's just, it makes the aging look good if you include that, but it's like, I'm not going to get that money for a really long time. So yeah, I think that there's always nuances like that. I think the MAP app does a better job of accounting for that because it's using the, the net AR from the financials, which also has additional reserves on it. So it's not at gross charges like it is in the Epic dashboard. So I think it makes it better. But it'd be interesting to see how, when you include all AR in the denominator, like how that changes the comparison.
Another question for you. So as organizations, nonprofits move to the new type of bad debt reporting, I'm not sure if WVU Medicine's doing this yet. FASB topic 606 changes how bad debt is reported. And Chuck, feel free to help me out here. But it changes bad debt expense to implicit price concessions. And so where bad debt goes to zero, that will definitely impact the bad debt map key that we have in MAP app. I guess my first question is, are you aware if WVU Medicine has moved to changing how bad debt has converted to how bad debt is reported?
I don't think that we have. I've heard some discussion about it, but I haven't. I mean, we haven't noticed a change in our financial packet, which we use to get some of the data that we report.
Okay, that's great.
Yeah, I'd have to look some more.
Yeah, they delayed the implementation again because of COVID. So there are a lot of organizations that were kind of in that last phase of converting. And just for those who aren't as familiar, and again, sorry, this is Chuck Alster with HFMA. It really fundamentally doesn't change your business. You're still going to try to collect every dollar. It's just it's accounting geography on the financial statement and the definitions of what bad debt is from a kind of a true financial reporting user of the financial statement. So we're working on, I think what Andrea is trying to get to is we're working on trying to create another metric that still gives you a good indicator for how you're performing with that population of accounts, but making sure that we're in alignment with the new lingo and accounting rules. So.
Thanks, Chuck. Yeah, I've been noticing that the bad debt benchmarks are coming down, the 75th and the 90th, because some organizations have converted to that new implicit price concession reporting. And of course, bad debt is zero. So that's going to drive down benchmarks. It's going to continue to as more and more organizations start reporting that way. So just in support of what Chuck was saying, we're trying to figure out how we still make, for those that are government hospitals who are not required to convert, how we continue to make that bad debt metric valuable in the tool.
So is bad debt still there somewhere, or it's not?
It is.
Yeah, I mean, what we've always considered bad debt, in other words, people not, the amounts that you wrote off because patients didn't pay. They're saying that you don't really anticipate to collect 100%. So instead of stating, let's say it's 90% you write off or 95%. Instead of calling this bad debt, that's really an implicit price concession because you don't anticipate you're really going to collect it. And so we're basically just renaming what we've always in healthcare known as bad debt. We're a very unique industry, right? I mean, not many industries have the bad debt levels that we do, or they'd probably be out of business. So that's that's the change. The bad debt from an accounting perspective will basically go to zero, and they moved it back to operating expenses. So if you're really interested, seriously though, the Principles and Practice Board Statement 15 goes through that, kind of the changes in uncompensated care reporting. And maybe, Andrew, we could share those as additional resources if people are curious. There's also an issues analysis we did that really walks through the detail. Yeah.
Yeah, thank you for mentioning that, Chuck. We'll definitely share that with the group.
And I think the last thing on that is, to Andrea's point, the GASB for entities that do report in GASB standards has not gone through revenue recognition yet. So if you're reporting in GASB, they're currently working on it. And so we'll see what there'll likely be, as usual, a difference in how they approach it versus the FASB.
Does that mean that people won't be so mad at me about bad debt all the time?
I think they're just going to call it something different.
Just moving it to a different bucket, right, Chuck?
They're naming it something different, and for Medicare cost report purposes, you need to make sure you're not putting those crossovers and Medicare bad debts into a contractual allowance account. So,
hey, can I just add one more thing? Is since we've been using the MAP app, we have seen our results get significantly better. I mean, part of it was the timing that we implemented it, but also I think just the visibility into where we are with these different metrics has really gotten our team focused in on trying to get our aging down and to get our days down, et cetera. And so, so I'm really excited about the rev cycle score that you were talking about that's coming out, because we definitely had it in our 5-year plan to hopefully apply for a MAP award. I mean, we're not close enough yet, but it is one of our goals. So I think it would be cool to see there every month, you know, your score changing. We got to get our point of service collections up.
That's great to hear, Leah. And thank you so much for taking the time to share how WVU Medicine uses MAP app with the rest of the subscriber base. We really, really appreciate your time.
Thank you.
Thank you, everybody.